Good morning, everybody. I'm going to be talking about Tourette syndrome today. I'm going to be talking about the overview of current treatment options specifically. This is my outline. We're going to talk about the introduction and pathophysiology of Tourette's. We're going to see how to approach a patient with Tourette syndrome, and we're going to dive in current treatment options. So when we're talking about Tourette's, we always think about tics. So tics are sudden, rapid, recurrent, non-rhythmic motor movements or vocalizations. This definition helps us differentiate it from other movement disorders. Usually it's involuntarily, but it can be voluntarily suppressed for varying lengths of time based on in different patients. So we can classify it as a simple and complex tic. So simple is usually quick and discrete, and the movement is usually confined in one muscle group. So it could be a diaphragm movement only or oropharynx movement only. So the complex one is usually coordinated. It's a series of movements or sounds, and it's usually involving multiple muscle groups, and it's purposeful in nature, and it sometimes takes longer duration than the simple one. So we have motor and vocal. Like we see, both could be simple or complex. So the common ones are listed here. Motor simple tic would be like shoulder shrugging, head or shoulder jerking. And complex would be a combination of simple tics, like simultaneously head turning together with a shoulder shrugging. That would be considered complex. Or it could be copropraxia, which is doing a tic-like sexual or obscene gesture. Or it could be echopraxia, which is imitating somebody else's movement. They can also present with dystonia or tonia positions, and some other purposeful movements that are listed here can be considered a complex motor. So when we talk about the vocal one, we have the simple ones like sniffing and throat clearing. And we have the complex ones like palilia, which is repeating one's own words, or echolalia, repeating others' word or last heard word or phrase, or coprolalia, which is usually associated with and commonly known with Tourette's, which is saying obscenities, or it could be racial or religious slurs. That one thing important that we should know is this vocal tics, they are forced out of them. They are abrupt and sharp, and we can differentiate it from a normal human interaction speech. So the other component we should know about is premonitory urge. These urges, they happen immediately before tics, and they are relieved by the execution of the tic. So mostly they are seen with complex tics, with head and neck tics and shoulder tics. They are very common. So they are described as tingling, feeling of tension or pressure. So for example, for eye tic, they might feel a foreign body sensation in the eye or a scratching sensation before the tic starts, and tickling sensation in the throat before they start the throat grunting. However, we should really know that it's not in all people, and some people might experience it in some of their tics while not experience it in the others. And the percentage of Tourette's people who have these urges is very much variable in studies. It can range from 37% to 100%. And one reason for it is the assumption of this urge, or knowing this perception and associating them with the tic. It might take time for especially children. And when they reach to adolescent age, about 90% of them report they have this urge. One importance of this urge is it can help us differentiate from functional tic, because it's usually seen in pathological tic rather than functional. This is a study that tried to describe where these urges are commonly seen. This is an older study, and they did a more recent one here. So what they found was it's very much dense and more commonly felt around the head and the face. It's more seen on the front of the body rather than the back. And the right and left distribution is not different actually in most patients. So there are two main factors that precipitate or exacerbate the tics. Temperament is one of it. Stress, anxiety, anger, excitement, fatigue, or illness tend to exacerbate it. And we have environment. This is observing gestures or sounds in another person. This is like this was seen in a COVID pandemic actually, which was very interesting that the incidence of tics in children and adolescents and young people increased dramatically during the pandemic. And different studies were done, and specifically teenage girls were affected by it. And the studies found
I had another visit.
The studies found that the most common cause that's the possible cause is anxiety associated with pandemic, or it could also be something they termed as TikTok tics, which is whenever a person has a tic and they record themselves and they spread it through this famous app TikTok, other people who are usually young people seeing these tics developed these tics, and it was associated with functional tic problems. So this was considered as mass sociogenic illness, like we've had many of those in history, like mass hysteria. So it was very interesting. So tics are better when we are calm and when they are calm and focused. For example, children who are doing their homeworks, when they are calm and focused on activities, they tend to have less tics. Okay, so the American Psychiatric Association recognizes 4 tic disorders. The first one is Tourette's. We have both motor and vocal tics for Tourette's, multiple of them, and for more than 1 year. And then we have, but what we have to know is the motor and the vocal tics, they are not necessarily concurrent, and their episodes may wax and wane in frequency. And we also have persistent or chronic tic disorder, which is one or more motor or vocal tics for more than 1 year. And the other is provisional disorder, which is one or more motor and or vocal tics for less than 1 year. So in all of them, the tic must start, the first onset must be before the age of 18, and other psychological effects of substance use or medical condition should be ruled out first. The fourth categories, other specified and unspecified tic disorder. That could be, for example, if a person fulfills all the criteria for Tourette's, but the first onset is after 18 years, we can diagnose it as this category and specify that we're not saying Tourette's because the onset is after 18 years. Or it could be something that cannot fulfill any of the criteria for these 3 disorders. One other thing that we have to know is functional impairment is not part of the diagnosis. Previously, it used to be, but functional impairment is not considered now to diagnose it. And this diagnosis are in hierarchical order. That means if we diagnose Tourette's disorder, we're not going to diagnose the other 3. The hierarchy is like I put it here. Okay, so when we talk about the pathophysiology, it's very for tics, it's very complex and multiple networks and circuits have been noted and still being studied and by researchers. The main part of it is usually the main tic generation starts in the cortex. That's the pre and primary motor cortex. And this generation is also taken to the basal ganglia, and the corticobasal ganglia circuits are involved. And we also have to see the premonitory urges, which are sometimes considered as being one of the mechanisms of tic production, tic happening. So that the urge are controlled with sensory, limbic and paralimbic part of the brain. Specifically, insula is very much associated with this urge. And the other is the comorbid symptoms like OCD or ADHD that happens with Tourette's is also happening within the corticobasal ganglia circuits. And on top of all these circuits being activated, the frontal lobe, which has the tick suppression power, that has been inhibited in some of the patients. So when we do, as we see later, behavioral therapy, we're trying to develop this part of the pathology and get the tick suppression back in order. And the other is behavioral component of the ticks, which is said to be controlled by neuromodulators like dopamine and noradrenaline. So genetic component is very strong. In some studies, about 92% of Tourette's is associated with genetics. The common inheritance pattern that's presented currently are polygenic, oligogenic, or bilineal inheritance patterns, which means from both parents. We also have some studies suggesting autoimmune association with pandas specifically, and environmental factors of obstetric complications are specifically linked, such as intrauterine insults or CS delivery pre-presentation. They've also seen early antibiotic exposure during neonate time. It might be a risk that's linked to Tourette syndrome. And some of the pathologies that have been recognized frequently in neuroimaging are reduction in caudate volume, variable rates of glucose utilization in the basal ganglia, and insulin involvement, like we said, with the urges. Okay, so when we see a patient with Tourette's, we have to know the diagnosis is clearly purely clinical, and we have to ask a detailed history. We have to remember to ask their urge, and the other part is observing the tics. Using videos to assist us with the observation. They can do video recording at home. That's also okay. And what we want to do is tick classification, like simple or complex, like we saw earlier, and seeing the severity. So the Yale Global Tick Severity Scale is the most common popular one. And we also have to see the comorbidities associated. ADHD is said to happen with Tourette's about 60% of the time, and OCD, anxiety, learning disorder, and conduct disorder. So evaluating this will change the management, so it's very crucial. Degree of functional impairment also should be assessed. This should be assessed in the eyes of the patient, also in the eyes of the caregiver, because functional impairment could be affecting the caregiver only, and it will change our management as well. And educating age-appropriate education for the patient, for the caregiver. Also, teacher in classroom is recommended, and telling them about the natural history of the disease, which is the average age of onset is around 6 years old, but it can be delayed until 21 years old. The peak of the symptom is around 10 to 12 years old, and then symptoms tend to decrease during adolescence and adulthood. There's a simple 1/3 rule where 1/3 of patients in adulthood completely resolve, 1/3 get improved, 1/3 continue with the same level of severity. And we also have to discuss with them the goal of treatment. With any of the treatment options out there currently, that goal of treatment is to reduce the tick frequency and severity and to improve quality of life. There's no cure, and that should be clear. So to generalize, after we diagnose Tourette's, we have to see if education alone is enough, or if they need treatment. If they need treatment, we have to assess comorbidities, and that has a different pathway of treatment. And if it is pure tick disorder, if it is mild to moderate tics, we can start with behavioral treatments, which is the initial choice of treatment. For severe tics, we can combine behavioral treatment with pharmacologic, which is alpha-adrenergic agent is considered to be first line currently. So what we have to know is American Academy of Neurology suggests that education behavioral treatment should be considered for everybody with Tourette's, even if it's mild, if accessible. Okay, so we can discuss about all the treatment options that we have today. So behavioral treatment is initial treatment option. Comprehensive behavioral intervention for tics, or CBIT, is the most famous one and most studied one. We've got habit reversal training, where we train them to be aware of their urges as well as recognizing tics. And then we have to train them in competing response training, which is training them to interrupt these tics by doing a specific behavior that is incompatible with the tic. And social support is a big part of this training. Functional-based treatment is basically identifying triggers. So on assessment, they should do a monitoring day-to-day activity to see what worsens the tic, what triggers it as well, and noting those activities and then intervening. And by intervention, we do anything to change their day-to-day activity or routine to minimize those triggers and impacts of tic. And relaxation training is also important. Progressive muscle relaxation and diaphragmatic breathing. Patient relaxation has been shown to decrease anxiety and then decrease tic worsening. The other behavioral treatment that we can consider is exposure and response prevention, which is basically saying we expose them to the urges and then we suppress the tics. That's the idea of it. Overall, behavioral treatment have limitations. Access is a big one. So insurance doesn't cover, most insurance don't cover this behavioral treatments. These are like 8 or more sessions, and it's very hard to cover them from pocket. Insufficient trained therapists on this field is also another limitation, and family support and patient compliance is much needed. So, and it needs a lot of focus to implement these therapies. And Tourette's, children who have Tourette syndrome together with ADHD, they may not be the typical patients for this treatment. And any patient with psychiatric or social problem, they may have a problem with compliance. So to address this limitation, virtual options are out there, such as tichelper.com. They give this behavioral treatments, and group treatments have also been implemented. But the efficiency difference from these options versus the one-to-one therapist option has not been studied very well. So when we go to pharmacologic treatments, we have we should consider drugs when we have multiple tics, self-injurious tics, when a person is not a good candidate for behavioral treatment, or they have failed it after trying it for about 4 to 10 weeks. Before starting any drug treatment, we have to tell them that it takes time to work. The goal is not cure, like we said. Fluctuation of Tourette's tic, the waxing and waning nature of tics makes it hard to see the progress and the improvement on the drugs. Sometimes the initial response that we're thinking happened because of the drug, it might be because the tics are waning. And the other is that when we're talking about drugs, FDA has approved only 3 drugs right now: haloperidol, pimozide, and aripiprazole. Okay, so this is a flow chart from Tourette Association of America. We have drugs that first-line drugs that we use off-label. Of course, the 3 drugs are not only FDA approved. These off-label drugs, the first one, alpha-adrenergic agonists, they generally reduce sympathetic outflow from CNS, and they're very good when ADHD is also occurring with Tourette's. And for people who have predominant behavioral symptoms, such as impulse control problems or rage attacks, they have been shown to be more good for those patients. And we get the benefit of these drugs without any drug-induced movement disorder, because the other options are antipsychotics, which we know that they can cause drug-induced movement disorder, which could be very difficult to differentiate from the tics, and it's very crucial to have these drugs without that side effect. And before moving to the other stages, we usually recommend 4 to 6 weeks to try out one medication first. And the next step would be to try atypical antipsychotics and then go into the typical ones. So managing comorbidities is a big part of management. Some studies have shown that when we treat the ADHD or OCD, the tics can be reduced. So for ADHD comorbidity, we can use stimulant or non-stimulant options. For the anxiety, we can use, or OCD, we can use the SSRIs. Rehabilitation is also a big part. Occupational therapy, physical therapy, and speech language pathology are recommended as of now. These are other options that are being studied. They don't have a very strong study and clinical trials behind them, but they should be considered for treatment-resistant Tourette's. So combination treatment is one of them, giving 2 or more combination of the drugs we talked about. Botox injection is the second, which is very much preferred for focal motor or phonic tics. For example, if we have a laryngeal, a vocal tic, we can give Botox for laryngeal muscles. The very important use of it is it doesn't go systemically, so it reduces the risk associated with systemic drug exposure. The limitation is it only works for a short time, 12 to 16 weeks, and then we have to repeat it. And it can cause weakness and hypophonia, and that should be also discussed with them. The other is cannabinoids. Currently, this for Tourette's is used in certain countries only. In Germany, Israel, and Canada, it's being used. It's not, AN says it's there's limited evidence for THC that it may be possibly more effective than placebo. CBD alone is not has not been shown to be effective, but there are very good progress being made regarding THC or derivatives. Actually, me and my colleagues are doing a systematic review on this topic, which is very much interesting, that it might be the future. Avoided in children and adolescents, that's recommended by AAN, and that's because the long-term cognitive effect that has been seen with cannabinoids in children. And the other one is deep brain stimulation. So it's not approved by FDA, of course. It's approved for other movement disorders like Parkinson, but not for this. But AAN recommends it for multiple drug treatment failure. And what we have to see is that there's 2 components of deep brain stimulation. There's neurostimulator here, like we see. This is the pulse generator. And we have electrodes that are seated inside the brain. So this pulse generator releases pulse. That's electric activity that is that can be actually programmable. It has we can program different pulse widths, frequency, amplitude of stimulation, and it can be controlled with a computer actually. And then there's a wire that connects that pulse generator to the electrode inside the brain in a specific area. that's also another problem in Tourette's because there's no one specific brain target that has been approved by all studies, but most basal ganglia area in thalamic area have been tried out and they've been working. The complications have to be discussed with patients. There are a lot of complications with infection is being the big one, bleeding, stroke, speech or cognitive or mood problems, and suicidal thoughts. And it's a very multidisciplinary approach should be used to choose a patient as well as to perform it, and careful patient selection should be done. Dental devices also have been tried out in some studies where the idea of it is it has a sensory trick. It has been more studied for dystonia, like cervical dystonia, where a patient bites on a dental device and that sends the sensory trick, which relieves the contraction, the spasm. For Tourette's, it's been studied on that's not been very well studied, but it's been shown it has shown improvement in some patients. Okay. What does the future hold? So there are some exciting studies like the median nerve stimulation study that's delivered with a watch-like device here. This idea was proposed in University of Nottingham, that's in UK. And the idea is indirect rhythmic electric stimulation of the peripheral nerve, that's the median nerve. It sends stimulation to the brain and that causes inhibition of the tics. And the clinical trial that they did, they showed that tic frequency has decreased in more than 25% reduction with effect size of 0.3. So that's very exciting. And on the clinical trial, what they did was they gave patients this watch to go wear it at home and deliver the pulse every 15 minutes. And they did it for 1 month, and as a response from that. The other is selective dopamine 1 receptor antagonist drug, EcoPPAM, that's being studied, which could be a good other option in the future. And advances in genetics and neuroimaging have been seen that has also promised a lot. Okay, thank you. If you have any questions.
Okay.